It's a pleasure for me to recognize and introduce one of the PIs, Dr. Sharon Walsh, who has been an investigator from NIDA for many, many years. And
Thank you, Nora. So just by way of introduction, my name is Sharon Walsh, and I'm the director of the Center on Drug and Alcohol Research at the University of Kentucky. And I have been involved in conducting research on opioid use disorder and its consequences for almost 30 years, and have been very fortunate to have been funded by NIDA and supported by NIDA and NIH throughout all of that time. I'm also the principal investigator for the Healing Communities project in Kentucky that was just announced last week, and we are absolutely thrilled. And it's also my privilege to introduce to you my colleague and partner on our Healing Communities project, Alex Elswick, who is a co-founder of a recovery services organization in Kentucky called Voices of Hope. And Alex is going to introduce himself and tell you a little bit about how he became interested in expanding recovery services.
Well, thank you. As Dr. Walsh has already mentioned, my name is Alex Elswick, and I'm a person in long-term recovery. I'm also a subject matter specialist for substance use prevention and recovery in cooperative extension at the University of Kentucky. And I'm a co-founder of a nonprofit organization in Lexington called Voices of Hope. And we're a recovery community organization, which means that our mission is to help people in recovery stay in recovery. And we're a grateful community partner as a part of the HEAL initiative. It's been a wild journey for me to get to where I am. And it's probably curious that I should use the word journey. I saw something on social media recently that said if you're the kind of person who describes your life as a journey, then you probably have had a DUI. And I said, hey, I resemble that remark. It's been a journey, and I have a DUI. I was born into risk factors for addiction. There's an extensive amount of addiction in my extended family. And from the time that I was young, I've struggled with anxiety. And I've been diagnosed with a number of different anxiety disorders throughout my life. So I was always looking for ways to cope with how I felt, ways to sort of self-medicate and manage my internal experience. And I think that's why I drew to drugs the way that I did, because as it turns out, chemicals work quite well for a time. I was first exposed to opioids when I was 18 years old, when I had oral surgery to have my wisdom teeth removed, and I was prescribed oxycodone. And despite the fact that I took my prescription as it was prescribed by my physician, I became addicted in short order, and then gradually made the change from taking oxycodone orally to snorting it, to shooting it, and eventually to shooting heroin. And my addiction took me most every place, most every bad place that a man can go. I went to jail. I went to a great many treatment centers. I went to halfway house. I spent the last days of my addiction homeless in a few different cities, and at the very end, sleeping under a bridge in Dayton, Ohio, and holding a cardboard sign that said homeless and hungry, and panhandling for money as a shot heroin. And my journey from then to now, almost 6 years, has not been linear. It's been up and down. And just as addiction is complex, certainly my recovery has been complex. There are any number of things I could point to that have enabled me to get to this place. But I would specifically identify two that are just important to me. And the first is that I was really fortunate to fall, as a matter of happy accident, into a continuum of care. So I spent 6 months in an inpatient treatment center, a Salvation Army in Dayton, Ohio, a free program actually. And as soon as I left the Salvation Army, the day that I walked out, I transitioned into 6 weeks of an intensive outpatient program. Not a day unsupported. And then the day that that program finished, I started working with a therapist. And I think that continuum of care has been critical to my success in recovery. And secondly, I had consistent access to mental health services. And for a person with a co-occurring anxiety disorder, that's been critical. Not only as a way to help me manage anxiety, but as a key to my recovery. And I'd like to finish by saying this. I've seen a lot of folks that I know here, and so many of you may have heard me say this, but oftentimes when I finish doing a speaking engagement, people approach me and they say the kindest things. And they say, Alex, we're proud of you because you're so strong and you're so brave and you're so resilient. And my ego desperately wants those things to be true, but despite my ego's protestations, they're not true. I'm not in recovery because I'm strong or because I grit my teeth hard enough or because I clench my fists hard enough or because I pull myself up by my bootstraps. I'm in recovery because I got access to evidence-based care and to a continuum of care. And I'll close by saying my best friend on this planet since I was 2 years old is at the Fayette County Detention Center right now on drug charges, and he has a substance use disorder. And the primary difference between he and I is not strength, is not willpower, it's access to care. Thank you.
Wow. So Alex, thank you for sharing that remarkable story and so inspiring us to remember why we were all here. I'm really glad you're up here as part of this panel. Sharon, can you say something to this group assembled here about Kentucky's plan? You were asked by NIH in a rather short timetable to come up with a proposal that would be truly oriented towards communities. You're an academic, but obviously the community contribution to healing communities by the very name was emphasized and asks many academics to get outside of their traditional zone. So how did you do this? Because as was mentioned, this went through rigorous peer review. We had a lot of applications. We put you through a site visit. I mean, we really kicked the tires of every one of these applications. And you succeeded. So what did you say that impressed us so much?
Well, let me start by how we formulated our team. Probably like the other awardees at the University of Kentucky, we have a broad range of experts who are very, very dedicated and passionate about this issue and have spent their careers trying to solve it from different angles. And so the first thing we really needed to do was see whether or not people were on board, because this was something that was going to take a village. And I can tell you that to the person, no one ever said no. And after we assembled that part of the team, then we just kept reaching out. So we went to all of our state partners who are in the position of making policy changes that can actually facilitate increasing access to care and changing the criminal justice process for managing people with substance use disorders. And we had a meeting with all of them, and no one said no. Everyone was incredibly enthusiastic and just offering how to help, what could they do. And we did the same thing time and time again with our community partners, the jailers, parole and probation, people that were working in public health with the syringe service programs, and everyone was so excited about it. So we knew that we had the expertise, and we knew that we had the community participation and dedication, and we just really needed to figure out how to put it all together. For us, we do a lot of research in the laboratory, in the clinic, and also in the community. And we know a lot about what works. We know a lot about what is efficacious from the science. And it's very frustrating sometimes to see what's actually happening at the community level when the science isn't translating sufficiently. And so we didn't actually ask whether we should put this grant together, which we knew was going to be a very heavy lift. We couldn't imagine not doing it because it was a once-in-a-lifetime chance to transform things within the state of Kentucky and hopefully to serve as a model that can be transported for every place else in the country.
Wonderful.
And then let me ask a question to both of you, because one of the areas, I mean, we wanted to bring the evidence-based intervention, but there is an area where the evidence base is almost non-existent. There is some research, but very minimal, which is recovery, which is what you represent. So how did you plan that? How are you going to actually evolve into something that we can learn from?
Yeah, so one of the things that we know is that opioid use disorder, like other substance use disorders, is a chronic disorder. And if we treat it like an acute disorder and we give someone a week's worth of treatment, it's not likely to have a long-lasting impact. And once someone is in evidence-based care and we get them into remission, which means maybe we've reduced some of the symptoms of the disorder, that doesn't mean that all the other problems are solved. And so what we know is that people need to have a support network, just like your last slide, talking about the importance of social support and social interaction. And one of those areas is providing recovery support services where people are welcome. There's less evidence about that. We have some studies that have been published on what works for long-term recovery, but this is a great opportunity with the Healing Community study to actually gather more evidence around what is effective. And Alex and his organization has been working on expanding recovery support services to individuals who are in recovery. And we really loved their model, and we've spent a lot of time talking about what their goals were. And we realized that for our project, that we could use that model and we could export it to places that may not have sufficient recovery services in place. So, for example, in some of our rural communities, by having Voices of Hope provide training for community members for developing and sustaining smart recovery programs. So there's a lot of 12-step and recovery meetings that are offered, but oftentimes people who are on medications are actually not allowed to attend them because they're not considered to be in recovery because of the stigma against medication. We want to break down that barrier. We want everyone to have a home, regardless of what their path is for their treatment.
Yeah, Dr. Walsh has the PhD, so she speaks about it eloquently. I just use my hands. If addiction is a chronic disease and we treat it acutely, people are unsupported for the majority of their lives. So relapse is sort of the inevitable result. And part of the idea with recovery support services is that they're extensive, but not necessarily intensive. So all of our services are peer-delivered, they're person-centered, they're strength-based. So for instance, we have a program of telephone recovery support where our volunteers, many of whom are people in recovery, call other people in recovery simply to say, how's your recovery going today? And how can I help you with your recovery today? And part of the idea is that there's not some strong-armed intervention, it's just a way of offering support, and that's why I was so glad to see the last slide that you showed. We know that social support is a critical element.
And again, as everybody is appreciating, but just to emphasize, we don't really know how to do this. So this is not a matter of, okay, we're going to deliver the services in these 4 places that we know are going to work. We don't know. Some of the things that you try in Kentucky or you tried in Ohio or in Massachusetts or in New York, they're going to fail. We're going to find out, well, that had the best of intentions and it made a lot of sense, but in that community at this time, the way that it was applied, it didn't have the expected result. We wanted that to be a part of the effort and to all learn from that. And that's another reason why this study needs to be transparent to everybody. There's a window that's going to be wide open for all of you to watch what's happening for healing communities. Can you put the slide up one more time that we started out with, just so that people can write down, if they didn't already, the URL. If you want to be aware and be informed and educated, starting now with what the Healing Communities study can teach all of us, if you go to that website and you see the URL up there in the upper right, or you can just Google Healing Communities, and then go to the place where there's that blue rectangle surrounded by red, and tap on it, it will ask you for your email address, and then you will be on this listserv, which will bring you regular updates about what's happening with healing communities. You'll be very much in the loop, because while we are funding only 4 areas, and we're expecting them to do a lot of really interesting work, the intention here is to have a much broader sweep of consequences for the whole nation. So please join us in that effort. We really want to learn from you as well. We have a data coordination center, RTI. They're going to be stepping into this space also to try to be sure that the lessons learned and the window of availability of information is as high-tech and available as it possibly can be. So sort of watch for that. But if you can get your email down at this point, we will be able to tell you step by step along the way what this community's study is teaching us.
Yeah, and I think, Frances, you mentioned, I mean, what are the things that are not going to work, but importantly, what are the ones that are going, what works, right? And we heard it, what is going to work, and what's very exciting is that the 4 different states have unique challenges and problems. So I think that one of the areas that I look forward on getting your feedback is how do you maximize that diversity yet at the same time come up with common elements. So what's your thinking, Sharon?
Well, the first task in trying to prepare the grant application was just to identify what we know works. What is the list of evidence? And I suspect, although we won't know until next week when all of the teams get together and share our applications with each other, I suspect that list is very common across the different states. That said, what we know is that there's this cavern between what we know and then what we do. And so I think the question is, how do we build that bridge? And I think in different communities, the answer to that is going to be different, and we're going to have to learn from the communities. How to build the bridge in an urban area where there are a lot of services, but maybe they're a little bit siloed, is a very different question than how do we deliver services in a rural area where there's maybe limited access to care, limited medical specialty care. And so for us, we have a very diverse portfolio of plans in order to try and be prepared to address that. That includes things like telehealth, enhancing our physician and provider network, providing support to pharmacists, addressing prescribing patterns, along with our state partners, to our physicians that may need a few more lessons still or haven't gotten the news about prescribing problems, how to overcome all the barriers that patients face when they're trying to get into treatment. If their insurance doesn't cover it or it's inadequate, how do we pay for transportation for people who can't get to their care? So we have a very large menu of things that we plan to deploy, and I suspect that when all of it is said and done and we're measuring what we actually deployed and how we did it, that the pattern of the resource utilization will look quite different across some of our communities. And I think it'll be an iterative process with the other sites so that we can really learn from one another.
Yeah, and another very important component, Sharon, and I would like to hear from you, because as you are saying, you're going to do this, but they have to be sustainable. So a key component here was the partnership that the NIH has with SAMHSA, but that you all have to with the states.
Yes.
So how did that evolve? How did that interaction come about?
Yes, so for people in the audience that don't know, this grant was unusual in many ways, but one of them was that you actually had to identify a key state government partner as an official on the grant. And the reasoning for that is exactly what Nora is saying, is that it has to be sustainable. And some of the things that we need to do to change the course of things actually have to do with changing policy. I'm not in a position to change policy. But in my case, my state government partner, who is Secretary Adam Meyer, who is the Secretary of the Cabinet for Health and Family Services, along with my other key partner, who is the Secretary for Justice and Public Safety, John Tilley. And then there's a whole cascade of characters that are people that I've worked with over the years on various initiatives around the state. And they're completely on board with this. And if I brought one of them up here, they could rattle off a whole list of policies that have been changed, legislation. We've got the 3-day limit on prescribing to try and be better stewards about our opioid use. We're just about to implement a policy to have Medicaid cover methadone treatment for the first time in the state of Kentucky. There's just a lot of creative, progressive things that are happening around the state, and we're working very closely with them also because the other funding that has come from the federal government through SAMHSA in the state opioid response funds and the STR funds is already being leveraged throughout each of the states in different ways. But it's not completely integrated, and what we want to do is we really want to leverage the money that's already being spent, for example, on naloxone supplies for overdose prevention. And so we worked very closely in formulating our plan so that we could capture some of those resources. We're not duplicating efforts, and we will be working very closely as a team as we move forward to make sure that the work is complementary.
Alex, at the end of Nora's presentation, she showed the scary graph of what's happening, not just with opioids, but also with stimulants, cocaine and methamphetamine coming up very quickly. In your program, Voices of Hope, I presume you encounter lots of individuals who are addicted not to just one substance, but to some mix. And that is apparently the way we're going to be seeing more and more of this. How do you deal with that in your recovery program? And Sharon, how are you planning to address that for the Healing Community Study? Because if we just think about this as opioids and nothing else, we're likely to miss the boat.
I think for us, at the end of the day, whether it's methamphetamine or it's heroin, it's still a chronic brain disorder. And so that people still need the same kind of social support. They still need the same kind of interactions. And so we have a brick and mortar location as of January in Lexington, and we host dozens of meetings every week. And one of the meetings we host now is a Crystal Meth Anonymous meeting. And I didn't even know that it existed, and one of our volunteers brought it to our attention, but I think it speaks to the very trend that you're talking about.
And I can just say that, I've been working in this area for a very long time, and in our research projects and in our clinics, it is very, very rare that you see someone who is using just a single drug. Polysubstance abuse is the norm. And so that's not something that we're unfamiliar with. And you're correct. It's not just opioid use disorder. The benefit, of working with people with opioid use disorder is that we actually have very effective treatments, and we have FDA-approved medications, as Nora said. Unfortunately, with methamphetamine, which really is a scourge, we don't have any treatments, pharmacological treatments yet. We have evidence-based behavioral treatments, and we need to make certain that the evidence around what is effective behavioral treatments and interventions is spread throughout our communities as well. I think that there are a number of promising things that are coming down the pipeline to address the stimulant disorder. I don't know if Nora wants to talk about any of that.
Well, they are in the side of medication, probably the most exciting area that we have that is likely to provide us with something that we can use is antibodies against methamphetamine. And Michael Owens is an investigator that actually is already conducting clinical trials to evaluate the efficacy of these monoclonal antibodies against methamphetamine. And this is the idea: if someone has an intoxication, for example, with a combination of fentanyl and methamphetamine, you can use the naloxone to revert the overdose, but it was not going to do anything for methamphetamine. So to be able to have the monoclonal antibodies could save the life of that person. So that's what we have right now, and we are working to try to develop these monoclonal antibodies so that they are have a longer half-life, so we can use them also for treatment. But there's another area that's very exciting in science, in the science of brain diseases, that includes also very exciting for pain, which is the use of neuromodulatory technologies like magnetic, transcranial magnetic stimulation or transcranial electrical stimulation, that you deploy very small currents of electrical activity or of magnetic fields into specific areas of the brain that are key nodes that actually regulate processes that are responsible for us craving, that are responsible for us to be able to exert self-regulation, or responsible for depression. So and studies have also shown that these technologies can be positive for helping patients deal with pain. So that's where we're seeing probably the faster deployment of new tools for managing cocaine or methamphetamine addiction.
Yes. So when we asked you to take an interest in applying for this opportunity, I think we told all the applicants that part of what we were expecting was, if you were successful in funding your set of communities, for Kentucky, I think it's 17 communities, everybody had to have at least 15 communities, that we would expect to see a drop in opioid overdose deaths of 40% in 3 years. That's incredibly bold. Are you worried about being held accountable to that kind of a milestone?
Are you?
I'm counting on you.
I think it's incredibly bold, and I think it's very ambitious, and I think that in the state of this crisis, it's been going on long enough that we really need to be bold.
I agree.
And so I think that we just need to bring everything to the table that we know, and we need to mobilize everyone, and we need to get this crisis under control. So I'm ready.
I'm glad, yeah.
I like that answer.
And Alex, if I ask you, I'm going to put you on the spot. Because you come from the communities, and we are reaching out to try to create ways of communities and academicians to learn from you. So what would you like? What would be, you sort of says, what would you like us to achieve through the healing communities? What would lead you to say this, apart from the issue that we're decreasing mortality, just from your perspective?
I think I would say two things, and the first is the mortality, right? I think I read somewhere in the promotional materials this morning that this week we'll lose 800 people to opioid overdose. And one of the things that we don't easily forget working in the communities is that those are faces and those are names and sons and daughters, and those are people we love and people we care about. So certainly any substantive reduction in overdose deaths is a big deal, and we're excited to see that. But I think for me, it's acknowledging that recovery is such an important piece of the puzzle, that for so long at these community forums that I attend, there's a seat at the table for enforcement and prevention and treatment, and recovery is sort of like the redheaded stepchild, sort of unaddressed. And I think one of the things that my experience taught me that our work in the Recovery Community Center teaches us is that people need that support over the long term. We were visiting a center here in Marietta called The Zone, and they have a full gym in there. And I just kept thinking how wonderful that people in recovery are exercising, that they're going to be healing their brains, that they're going to be doing it in community. What an asset that is.
Yeah, Alex, you said something when we talked earlier about how when you have to give up a reward system, and let's admit that opioids is a very powerful reward system, you need to have something that becomes your new reward and not just deprivation plus nothing.
Right.
So clearly that's something your Voices of Hope knows really well. Clearly that's something that this program is going to incorporate into your community awareness. But I'm not sure many of our other research projects have thought that deeply about not just the need to stop, but the need to start something powerful, meaningful to the person. We have to figure out how to do that better.
Frequently, I tell people there's a difference between sobriety and recovery. That sobriety is about what you don't do, not using drugs and alcohol, but recovery is something entirely different. It's about what you do instead. So for me, that's lifting a lot of weights and playing a lot of golf.
And working on his PhD.
Yes, that too.
Good.
Oh, that too, yes. Sharon, any final words you'd like to say as we're about to run out the clock here in terms of what about this program has you excited and what message you might want this audience to think about as they watch what happens over the course of the coming months?
Well, I want to thank NIH and I want to thank the federal government for having the vision to do something so bold. This is unlike anything else. I mean, this is like our moonshot in our field. And I think that it is going to be incredibly transformative. And for everyone that is going to be part of this team at the research sites and our data coordinating center, we all are facing a tremendous amount of work. We know that this is going to be a really heavy lift, but I think I like to think looking down the road 3 years from now, 3.5 years from now, when we've seen that downturn on our dashboard of how much we've decreased deaths, and knowing that the HEAL initiative has played a very big part of that.
That's wonderful to imagine coming forward. I'm counting on you and all the rest of our wonderful teams here to make it so, but actually on everybody in this room, because again, this is a national effort focused in these 4 places, but something that we are all going to learn from. Please join me in thanking our panel.